Team, it is live, right? Ankit ji?
1 second, sir. I'll let you know, sir.
Okay, right.
Yes, sir. We are good to go.
Great. So, good evening, everyone, for yet another workshop on no thrombosis. It's a great initiative where we have none other than Dr. Ichapuria sir taking us through some interesting cases and having a nice panel discussion regarding the same. So, without further ado, it's a pleasure to welcome you here, sir, today. Sir is our course director, Dr. Ichapuria, and of course, he doesn't require any introduction from our end. Sir is a director neurology at the Sahyadri Hospital, Yerwada. So is the first neuro ICU and neuro intensive care unit of Pune. He has been a pioneer in the field of thrombolysis treatment for stroke in India. More than 300 public lectures have been delivered by Sir and a lot of workshops as well. He's a member of Indian Stroke Association and the organizing president of StrokeCon 2012 and the organizing president of ISA's Stroke School. Sir is the founder of the Pune Stroke Group, ex-president of the Society of Neurosciences Pune and Maharashtra Academy of Neurology. Sir is as a principal investigator for many multinational stroke trials like Perform, BrainSkate, BC12, cortical venous thrombosis, Interact 2, etc. Sir has been awarded as the health icon by the Times of India Group. It's an honor and pleasure, sir, to welcome you here today for this no thrombosis workshop. With this, we'll move towards our esteemed moderator for today. We have Dr. Nathaniel Sase. Sir is a professor and head of neurology unit at the GMC Mirage. Sir is an experienced neurologist with a distinguished career spanning over 3 decades. He's completed his MBBS and MD in internal medicine from Shivaji University. Then he's pursued a DM in neurology from MGR Medical University, Tamil Nadu. Sir is actively involved in clinical practice and academics and has served in the Department of Medicine at Wanless Hospital, Mirage, before specializing in neurology at CMC Hospital, Mirage. Since 1994, Sir has been a senior neurologist at Wanless Hospital, Mirage, where he continues to provide expert care. In 2012, Sir was appointed as the director of Wanless Hospital. In addition to his clinical roles, Sir has contributed significantly to the medical education as well. He was a lecturer at the Government Medical College Mirage and has served as a postgraduate teacher and examiner in medicine at MUHS Nashik. It's a pleasure to have you here, sir, today for this no thrombosis event. With this, we also have our second moderator, Dr. Sunil Gajre. Sir is the director and consultant neurologist at the Gajre Hospital, Jalgaon. Sir is a fellow of the Royal Medicine London and a member of American Academy of Neurology, also a member of the Maharashtra Association of Neurology. Sir has done many conferences internationally and locally and has many research topics like herpes simplex, encephalitis, chikungunya, Guillain-Barré syndrome, etc. He's been a part of various drug trials such as chronopreparation for valproate in epilepsy. Sir has also written various articles on epilepsy management. Sir has attended various conferences internationally and locally in the field of stroke and interests in history, archaeology, wildlife, alongside extensive travel to historical and archaeological sites worldwide. It's a pleasure to have you here, sir, today for No Thrombosis. With this, we'll move to our speaker for today, Dr. Kaushik Datta. Sir is a consultant neurologist at the Manipal Hospitals, Kolkata. Sir has been an MBBS from the Medical College, Kolkata, and DPM from NRSMCH, Kolkata. Sir is an MD Medicine from Maulana Azad, New Delhi, and DM Neurology from WBUHS. Postdoctoral fellowship in epileptology from JIPMER in New Delhi, and is a master school certificate in headache management from International Headache Society. Sir is currently attached as a consultant neurologist at AMRI Hospital, Kolkata. Thank you, sir. We are very enlightened to have you here, sir, today for this no thrombosis event. And finally, our second speaker, Dr. Gajanan Patil, who's a stroke physician at the Sahyadri Hospital, Nagar Road. Sir is a leading stroke physician working in Pune alongside Dr. Ichaporia in the advanced stroke unit. He's highly experienced in the management of acute ischemic stroke with special expertise in thrombolysis and evidence-based acute stroke care. With years of clinical practice, Dr. Patil has been at the forefront of establishing timely stroke interventions, ensuring patients receive rapid treatment within the golden window period. His dedication has contributed significantly to improving outcomes for stroke patients in Pune and the surrounding regions. He is recognized among peers for his clinical acumen, patient centered approach, and leadership in stroke management protocols, making him one of the most trusted specialists in this critical care area. With this, I hand over the dais to Dr. Ichaporia and Dr. Patil to take us through the first interesting case in the field of stroke. Over to you, sir.
Yeah, thank you. It is a great pleasure to be here for this next no thrombosis program, which has been run very successfully for the last 1.5 to 2 years. And we've had some very, very exciting cases and very many new things to learn for all of us. And I'm sure today will be the same. I very warmly welcome my dear friends, Dr. Sunil Gajare, who is my colleague and a very senior and well-respected neurologist from Jalgaon. And he was telling me that he has done the maximum number of stroke thrombolysis in northern Maharashtra in the last 2 or 3 years. So welcome to you, Dr. Sunil. And is Dr. Sase around?
Sir is joining in 1 to 2 minutes.
Yeah. So shall we start with the first case, Dr. Sunil?
Yeah, I think so. There's no, let us start. It's already 12 minutes late.
So Dr. Krishna?
Dr. Gajanan Patil.
Who's starting first?
Dr. Gajanan Patil.
Dr. Gajanan. Okay, Gajanan, are you ready?
Gajanan, starts sharing your screen.
Yes, just a minute.
You will discuss.
Is it? Good evening, everyone. Myself, Dr. Gajanan. I'm working with Dr. Ichaporia, sir. Last more than 15 years, and we're working together and helping many stroke patients. Is it audible?
Yes,
Yeah,
audible and visible.
Yes, sir.
Continue.
Thank you, sir. So, this is my case. 76-year male presented with fall in bathroom while he was having bath on 14th March 2025 at 9:30 a.m. The relative broke the door and took him out and called the ambulance. He came to ER and he has, when we examined there, the core stroke was called, and he has hot water burn on abdomen and thigh regions, multiple superficial blebs, and right side upper limb and lower limb weakness since 9:30 a.m. So he was endo-parade. So, so before coming to hospital, ambulance doctor pre-notified to neuro team. Clinically, BP was 163/89, pulse was 103 beats per minute. He was right hemiplegia with mild facial weakness. Speech was normal. GCS 15/15. National Institute of Health stroke scale was 10. He has multiple blebs all over abdomen and thighs regions. This was his all blebs all over abdomen, upper front and back also trunk, and there is thigh also involvement.
Why were there blebs?
Because sir, he has he went to take a bath at around 9:30, 9:15 around this thing, and he's fell down and he was taking this hot water from the bucket, so he was fall on that, sir. And
Okay,
they're all
so there are burn marks.
burn marks, sir. So he was all hot water all over body, and he becomes that blebs developed.
Scalds.
Yes, sir.
Hmm.
So we were worried, and patient relative also worried about these things because burn also was there. So he is within window period. So what will be the next? Whether you should go for imaging, call the surgeon doctor for burn to tackle with this acute hot water burn, follow the stroke protocol, or do anything others. So we, because acute ischemic stroke and window periods, we done CT scan imaging. There is no acute hemorrhage, and there is no acute any subdural hematoma because it is stroke fall. So any angio shows there is a left MCM1 distal occlusion. So because of this acute left MCA stroke and underlying left MCM1 occlusion, we thrombolize with injection tenecteplase within 8 minutes. Why we did these things? Because due to pre-notified patients, when called the ambulance and doctor went there, our AR doctor went there at home, and he immediately informed us, neuro team, this patient is developed right side weakness, and he had unable to get up, so there is a stroke. So he pre-notified to us, stroke neuro team. So we patient, when he came to emergency department by ambulance, we took the patient directly taken from ambulance to CT scan department. So door to nil time was 8 minutes. So we reduced the door to nil time. We always reduce around 15 minutes without pre-notify. But after pre-notify, we reduce the door to nil time another 4 minutes. So in large vessel occlusion, patient taken to mechanical thrombectomy.
No, but Dr. Gajanan.
Yes, sir.
What did he do in the ambulance?
We did.
What did the ER doctor do in the ambulance?
Yes, sir. We in ER doctor in ambulance, we did BSL check first with their this stroke mimic like hypoglycemia. They evaluated. They took the intracath, large bore intracath, like 18 number intracath in situ, and then everything was ready. That's why we had taken the patient directly ambulance to the CT scan department, and we save the time.
Was the ECG done in the ambulance?
We are not done, sir, because we are done later, because that movement artifact which comes in ambulance, sir, actually.
So what was the advantage of that fellow, that doctor, ER doctor, going in the ambulance? What was the advantage?
So we are reducing door to nil time and give best treatment as early as possible to achieve our this thing, sir.
Okay.
Stroke treatment.
Okay, fine.
Yes. So this was our stroke stopwatch. We are started when he is immediately enter the ER, and this needle time we have stopped that watch. The exact 8 minutes was there, and we had shifted patient directly in mechanic thrombectomy. This was a stump here, left MCA is occluded, and this is the guide wire with these things. This is unable to see this after distal MCA. And after first pass with penumbra, the vessels was opened, these things, up to distal branches. And this was clot removed. Red fibrin patch plaque we removed, blood clot. Yes.
You should put one scale there, huh?
Yes, sir. Yes.
Because we cannot make out the length of the clot.
Yes, sir. So we as soon as we are done this mechanical thrombectomy, we are done on table only. This CT scan run the CT scan, And this shows there is an extravasation of dye due to capillary leak here. And after 3 days, on third day, patient was walking. Mild facial was there, but he improved on the follow-up. So this was our previous was almost 6-7 years. We had done door to nil time was 14.3 minutes, and we this celebrated this door to nil time 8 minutes. This is our mentor, Sir Ichhabra sir, and this is our team, and this is our his unit head, and this was the fellow, this blue dress, Dr. Jayesh. So he informed us, pre-notified, and we achieved 8 minutes door to nil time. And we went to Lucknow. So Dr. Shri Hastak sir done our appreciations. This is our stroke team and neuro ICU team. And because of our work, we are getting consecutive diamond awards. Thank you.
So what message do you want to give, Dr. Gajanan?
My message in that usually pre-notification is very important in this scenario, and as soon as pre-notify, we can keep ready CT scan department, ER department, and we little bit sideline the ER department, and we patient took directly from the ambulance to the direct CT scan, and we achieved door to nil time, reduce the door to nil time. That is our aim.
How much time did it take to open up the vessel by mechanical thrombectomy?
35 minutes, sir. 35 minutes.
So groin puncture to?
Puncture to recanalation is the 35 minutes.
So how long did it take to do the groin puncture?
It was that is also 30 minutes.
So maybe we can reduce that further.
Yes, sir.
So the message that Dr. Gajanan, so final message, what do you want to give?
My final message, sir, is pre-notification and best medical management with intervention. We achieved MRS, this modifier ranking scale achieved very well in this case, and his modifier ranking is almost 0 now after 3 months, and baseline we have to achieve modifier ranking scale.
Yeah.
I think I can come in here.
Yes.
What you have done is a wonderful job. From the onset till removing the thrombus is a very good thing and done in a very quick manner. Now, if there had not been any of those burn marks,
yes,
would
sir.
you have first given tenecteplase, waited, and then done a mechanical thrombectomy, or you don't want to spend time giving tenecteplase?
No,
No,
we
sir.
gave tenecteplase.
We gave tenecteplase, sir.
Acha, you gave tenecteplase.
We gave tenecteplase within 8 minutes. So door to needle time for tenecteplase.
Sorry, what I thought was that because of the burn marks, you would hesitate to give tenecteplase because bleeding might occur. But I mean, usually I would also do the same. But in this particular case, I would not have given tenecteplase and directly sent for mechanical thrombectomy because of the burn marks.
No, but you see, Dr. Gajre, what our reasoning was that even if those burn marks were there, it is a compressible site.
Yeah, it is.
Even if it bleeds, you can compress it. It is not some deep-seated thing like peritoneal or abdominal or chest. It is on the skin. So even if it bled, which it didn't actually, but even if it did, we could compress it.
Okay,
So
okay.
if it,
Yeah.
because it was superficial, we did not take that into consideration, and we said that no, that is not a contraindication whatsoever, and we should not miss the opportunity of giving tenecteplase. And tenecteplase was given after this plain CT scan. Gajanan, when did
Yes,
you
sir.
give the tenecteplase?
After plain CT scan only, sir.
Or did you wait till
No,
for
not
the
waited
CT
for
angio?
No, sir.
So what was the sequence?
We
He came to the casualty door.
Yes,
You
sir.
took
We
him
done
to the CT
CT
scan.
scan. We did CT scan with thrombolize. We finished the CT angio, and then we convinced the relatives about we can go ahead for this mechanical thrombectomy. And we within 30 minutes we took him to the cath lab immediately.
Now you see, a lot of credit should go to the ER doctor, Dr. Jayesh,
Yes.
because in the ambulance he primed the family. He took the consent. He did the sugar. He did the NIHSS. He pre-informed the casualty so that directly the patient could be taken to the CT scan. CT scan was kept vacant. It was during working hours. It was a busy time in the hospital. So the CT scan had to be kept vacant. So a lot of credit goes to the emergency room doctor who actually is a NIHSS trained person. Most of our ER people are NIHSS trained, and because they are NIHSS trained, and he had worked with us previously also, and then he joined the ER, so he knew what stroke was. So the message that we want to give is how pre-notification helps, how in the ambulance you can do all the basic work. You can take the consent, you can do the blood sugar, you can look for any contraindications, you can take the history. So easily you avoid 5 to 7 minutes of the ER work. And straight you take him to the CT scan, do the CT scan within minutes, within 2 or 3 minutes. And then don't wait for the CT angio. Give the IV tenecteplase. You see, of course, contraindications, and the relatives were ready because they were primed already in the ambulance that this is the situation, and so therefore within 8 minutes we could achieve this. And I think this is, for us at least, it is a record. So we were very proud of the fact that we could do it within 8 minutes. And then the whole cascade started of informing the cath lab. Cath lab takes time. The interventionist takes time to come. So it took about half an hour. I think half an hour is reasonable
That was on
for Pune traffic at 10 o'clock in the morning. Though we would like an in-house person who is there 24/7, but it's not possible, you see.
that was on Rang Panchami, sir.
Huh?
That was on Rang Panchami that day.
It was what?
Rang Panchami.
It was Rang Panchami.
Yes, sir.
Okay. So it was a holiday.
Holiday, and that doctor was in the playing with that.
Yes, now I remember. That doctor was playing with her children Rang Panchami. Oh, it was Holy Day. It was not Rang Panchami.
Yeah.
It was Holy Day.
Friday.
And she was playing with her children, and she had kept her mobile phone aside. And she didn't see her mobile phone because she was playing with the colors. And then finally, when she saw the thing, so she came to the hospital. Yes, now I remember. So all these roadblocks are there. But in the meantime, the cath lab was prepared, and her junior staff already prepared the patient and had done the groin puncture. And then the main doctor came to do the mechanical thrombectomy. So this is how the cascade works. And for this, you need a big team. You can't do this alone. So what we are trying to emphasize is that we need a stroke team who is available round the clock. It's very difficult to be round the clock, but that is how it should be. And for this, we could achieve such a good result with a door to needle time, which was low. Dr. Sunil.
Yeah, wonderful job. I mean, there's two things. One, he could have done the ECG in the ambulance itself, because That would give you more insight. But anyway, that is one more thing. And secondly, is it is true that all bleeding stops with compression. But these elderly people, if they have burns and they start bleeding and you compress, lot of pain. So otherwise, I also always give tenecteplase even for large vessel occlusions. And if it opens up, excellent. You save a lot of money. And unfortunately, if it doesn't open up, then you have to go in and remove the clot. So those are two things. Of course, practices differ. And lastly, is that many patients they can't afford all of this. That is the thing, that unless we have the prices of tenecteplase come down and the prices of the catheter and made in India stuff, it won't be very popular. And it's perfectly right that we should have in-house interventionists. But even the West, most of the American hospitals don't have it. But then there are things which are not always possible. But the thing is that you do your best, and that is what you and Gajanan and the team has done. Excellent work. Very good.
Yes. Yes, Sunil, your point is very valid because we always like to give tenecteplase uh, before even large vessel occlusion. And to our great delight, many times, interventionists don't agree with me and they always fight with me. But many times, uh, uh, 30, 40, 50% of the time, even the MCA vessel opens up. And you save a tremendous amount of resources by this maneuver. And
Well,
really, we are extremely happy with tenecteplase because many large vessel occlusions do open up. So I would really
yes.
urge everyone to give tenecteplase, especially if you give it early. If the clot size
Yes.
is small and you give it early, many of these clots do dissolve and the vessel opens up to our great delight. And then you can save so much cost, so much ICU stay, so much cath lab, this thing, and you save easily 5 to 10 lakh rupees easily. So therefore, we always like to give thrombolytic agents, especially tenecteplase, as soon as possible to every patient who is eligible, and not to wait and do direct mechanical thrombectomy, except if there is bleeding somewhere, or there is a severe contraindication for giving IV therapy. Unless that is there, which is a minority, unless that is there, we would always like to give IV therapy before we do mechanical thrombectomy. And perhaps it may soften up the clot and make mechanical thrombectomy also easier. We don't know. We don't have data on that. But perhaps that is also the case. So I would
Well,
urge everyone, even who are in the periphery. Now you see, 95% of the world 95% of the world cannot afford or have access to mechanical thrombectomy.
yes, true.
95% of the world. Okay, very developed countries and all these trials have been done in all developed countries and in a trial setting. First trial was done in Holland, which is a flat country. Flat, absolutely flat. People go to work on a cycle. There are no hills. So, you can transport the patients. It's a small country, about the size of Goa or something, maybe a little more than that. So you can transport the patient very rapidly. But in our situation, rural areas, monsoon time, very difficult. So we rely a lot on IV therapy, and we are really very happy with it. And surprisingly, many patients do improve. So kindly use it. Of course, if you have the facilities, you should do mechanical thrombectomy. There's absolutely no doubt. But what message we want to give people who do not have access to mechanical thrombectomy? Large parts of India do not have. So definitely use IV therapy, and you'll be surprised how many times it works and works really well. Yes,
Can
Sunil.
I request Gajanan? Well,
Yes, sir.
since you have a team, collect those cases where you have done given tenecteplase place first and done mechanical thrombectomy versus those cases where you haven't, where the clot hasn't opened up and you had to go and do mechanical thrombectomy and do present it in one of these stroke meetings. It will be very good data.
Yes.
Yes, sir. Definitely.
Yes, very good suggestion,
Yes.
indeed.
Thank you, sir.
Yeah. Yeah. Any more comments from anyone? Dr. Kaushik?
Yeah. Am I audible, sir?
Yeah, but can you comment on this case?
Yeah, but actually, in this case, the speed of management is what attracts me the best. And as per the protocol, everything was done, and that was done very fast. The best thing was that the patient was brought into the hospital very fast. Pre-notification was done, and as you mentioned, that the emergency doctor did a very good job. Only probably the ECG could have been done, that would have been added, but all the other things. The most important thing is priming the patient, where we lose most of the time. Since I work in Kolkata, and for us, the roads are a very big problem. A person coming from the outskirts of our city hardly are able to reach the hospitals within the golden hour. Uh, Only people from the neighborhoods, they can reach the hospital within the golden hour. Roads are a big problem, and this pre-notification thing and priming, that's another big problem. And most of our corporate hospitals, they refuse to send ambulances to patients who stay, say, about more than 5 kilometers away. So those patients will be transported to the hospital in their own ambulances, different ambulances that take time, and after they reach, they are often confused. When we try to prime them, they would like to discuss with the general physicians that they usually see. And what we are trying to do is, right now, we are, for the last few years, we have been trying to sensitize the general physicians, so that while referring the patients to the hospitals, they already prime the patients that this sort of a therapy may be required. Otherwise, when they come to a corporate hospital and they suddenly meet new doctors, there is a trust issue. They often tend to hesitate, and we lose very valuable time. So this was a wonderfully managed case, I should say.
How much did it cost? Total cost for the thrombectomy and all of it?
Costs are high, about 5 lakhs.
It's all right. I mean,
Yeah,
the
but
materials
it's not
is so high.
this patient, finally they fought with us. Cost is too much. That went on and on. And finally, they had to pay the cost. I mean, it cost that much. So it is a real issue in our country. Even sometimes, people have insurance of 2 lakhs and 3 lakhs, and this thing goes up to, 4, 5 lakhs easily on day one. And
Yeah,
then
it does.
if there is an issue and he goes into the ICU and stays there for a prolonged time, then costs just jump up like anything.
Yeah, I
Then
mean,
it becomes crazy. And so many times I feel that, we have to select our patients very well. By increasing the cost, we are jeopardizing the family. They have to sell their property, gold,
yeah.
house, car, all that stuff. And so we have to be very careful with what we do. Our hospital is not in a very rich area with all the elite staff. We are catering to the middle class, lower middle class, and also the upper class to some extent. But we have a large segment which is lower middle class. So it is a strain on the family. There's no doubt. And if things don't go well, then yes, we do have problems. We can't run away from those problems.
We can't. That's true. Unless the economy improves,
So
insurance
unless the
improves.
GDP of the whole nation improves,
Yeah, unless it reaches
I'm just
the.
waiting for the day when, people will give consent for mechanical thrombectomy without batting an eyelid. But that day is far away.
Why I can manage to do a lot of these thrombolysis is that the hospital is insured for railway, central railway, and ESIC, and they approve 1080 plays. So
Yeah, so that something
it
like
has
that, if it happens.
yeah, so most
Yeah.
of these patients are not paying from their pocket.
1080
Otherwise,
plays, people can afford 1 and 2 lakhs. That's not much. Yeah, I mean, it is a strain, but it's not too much of a strain. But mechanical going up to 5, 7, 8, 10 lakhs,
no, it's very
it becomes
difficult.
it becomes very cumbersome. And of course, this patient, though they were well off, we had an issue of getting the bill out of them.
It does happen. It
Yeah,
does
yeah,
happen.
yeah. Okay, Dr. Kaushik, could you take your case?
Thank you, sir.
Yeah.
Yes, sir. I'm presenting your case. Yes.
Yeah.
Yep.
Please share, because I couldn't log in from my laptop and couldn't log in from my mobile also. So I have to log in from the hospital computer, and my presentation is not saved here.
Yes, sir. I think it is visible now.
Sure. Yes, it's visible. So thank you, sir, for allowing me to speak in this session. After the first case, which was a wonderfully managed case, was the slogan "Time is Brain" was actually put into practice. The second case, this one that I present, is basically a story of lost time. But this case has its own merit. It will teach us something. And since I am not a very knowledgeable person, I'll invite interactions from the knowledgeable audience at certain points while presenting my case. Please, the next slide, please. This patient was basically a 30 years old male patient who, can I have the next slide? A 30-year-old male patient who developed repeated episodes of rhythmic jerking of the left upper limb. And during some episodes, the left lower limb will also have those jerks. So this was much before the admission. And he had post-ictal headache for about an hour after each episode. The power of his left-sided limbs would recover quickly during the initial episodes. But during the later episodes, the left upper limb remained weak for about 30 to 40 minutes, while the left lower limb would recover fast. Loss of consciousness was not reported during any of the episodes. The next slide, please. So this man was basically executive at a multinational company, and he had no history of diabetes or hypertension, no substance use, a workaholic, but his working pattern was sedentary. Can I have the next slide, please? Work was very sedentary, but he started exercising around the age of 27 years. He felt tired after the exercises and had thigh muscle cramps. And for this reason, he undertook a lot of tests, including ECG, echocardiogram, thyroid function test, kidney function test, CBC, cholesterol, triglycerides, and all these things were normal. And he felt better after taking some multivitamin, which he stopped later. Next slide, please. So initially he was, after having the abnormal jerks, he was initially seen by a physician who diagnosed seizures and started him on levetiracetam. He had apparent benefit for some days, then those jerks recurred. And then he was seen by a neurologist outside, and who increased the dose of levetiracetam and added lacosamide. One EEG from outside was reported as cortical dysrhythmia, but when we looked at the graph, we found only artifacts and nothing else. MRI brain epilepsy protocol was advised, but it was not done due to a metal implant that the patient had. Next slide, please. On the day prior to admission to our hospital, he developed sudden onset of dysarthria, followed by deviation of the angle of mouth to the right side, weakness of the left-sided limbs around 9:30 p.m. at night. And then rapidly, within half an hour, he became unconscious. He was taken to another hospital where he was intubated and started on mechanical ventilation. He was transferred to our hospital at night, and he reached our emergency room around 3 a.m. Then I was called and I had to come to the hospital. After receiving the call, I probably reached within 40-45 minutes. And by the time he reached our hospital, we were already out of the golden hours for thrombolysis and everything. And when I examined the patient, his GCS was C1M1VT, almost nothing was there. Next slide, please. So this was the initial CT scan that we could do. You can see in this CT scan that he already had well-developed right-sided right MCA territory infarct. It's quite large and already out of window period for thrombolysis. We discussed about mechanical thrombectomy, but the patient and the family didn't agree with that. And already the size was quite large. And when they asked us about the risks and benefits, we had to explain the risks of having a big bleeding because the core is already apparently large. And because of the implant, we couldn't do the MRI, and we don't have the CT perfusion software. So this was all we had. Next slide, please.
But Dr. Kaushik, is there an infarct on the left side also?
No, sir, there was no infarct on the left side.
Just go back to the previous scan. Yeah, on the left side, in the parietal region also there is some hypodensity. Did you think that there is an infarct there?
No, there was no infarct there, sir. Probably due to the asymmetry of positioning, the patient. This is an artifact, most likely.
Okay. Because you can't see the sulci and gyri on that side.
Yes, sir. Yes,
so,
sir.
Early ischemic change was what I was thinking of.
If you look at it, sir, the Sylvian fissure on the left side is quite prominent.
Yeah.
And those things
behind
are
the Sylvian fissure.
Yeah. And behind the Sylvian fissure, probably in the here in the temporoparietal area. But actually, this is probably an artifact because of the improper positioning of the patient. There is some asymmetry in positioning of the patient.
Carry on, sir.
Okay. Next slide, please. And this was the CT scan done on the next day after about 24 hours. And you can see that it's a large right hemispheric infarct, the large right MCA territory infarct involving both the superior and inferior divisions. And next slide, please. And this is the CT angiogram that we could do. And you can see that there is a cutoff in the right MCA after a certain point. And next slide, please. This is another picture from the poor flow in the right MCA territory is there. Next slide. But the interesting case is, here I invite discussion from the audience. What was the previous phenomenon that he was having that was treated by his physician and a neurologist outside? All those seemingly focal seizures that he was having.
Was it a limb-shaking TIA?
Yes, sir. That was a limb-shaking TIA, most probably because he landed up with the stroke, and in hindsight, we thought that it was a limb-shaking TIA.
Yeah, but was it occurring in the erect position or when he was lying down?
Most of those occurred in the erect position when he was working. Most of the time when he was working.
This limb-shaking TIA can mimic a seizure.
Yes.
And usually, classically, it's rare. Huh? It's a very rare phenomenon.
It's very rare.
But it occurs, when the person is erect and the cerebral blood flow decreases, and
Yes.
if you keep the patient flat, it disappears.
Usually, yes, sir.
Do you
Yes.
have by any chance a video of it?
No, we don't. We don't have, because all those limb shaking TIAs occurred before
Okay.
he landed up with the stroke, and
Yeah, because I haven't seen it. I mean, it is mentioned, but I haven't seen it.
yes.
No, it's
I
rare.
was-
Certainly, it's certainly a rare phenomena. I've seen one or two, and they are dramatic. They are really dramatic. They really look like a seizure, but it almost always occurs in the erect position, and you make the patient flat, and it
Yes, sir.
disappears, and the
Almost like,
consciousness is preserved.
yes,
And what
yes.
is the reason for it?
Sir,
Ischemia of the hypoperfusion.
of
So
the
when
retina.
he's erect, the blood doesn't reach the
Yeah,
motor
yeah,
cortex,
yeah, yeah.
and when
And
he's flat, it
usually,
reaches
so,
it.
this will usually occur with an ICAD, not an embolic stroke. So probably
Yes,
there is stenosis of the MCA, large vessel occlusion, or
yes, sir.
stenosis of the MCA or ICA usually,
Yes, sir.
and
Mhm.
it produces ischemia on that cerebral hemisphere in the erect position. And so here the ICA looks okay, but the
Yes,
MCA looks a little shaggy and
yes, sir.
tapering off. So mostly it is an intracranial artery, intracranial atherosclerotic lesion,
Yes, sir.
uh, producing ICAD and cerebral ischemia. That is my conjecture. What is
Yes,
it?
sir.
What is your view, Dr. Kaushik?
Yes, sir. We also, in hindsight, we diagnosed it as limb shaking TIA. May I have the next slide, please? So, uh, the thing is, no, the previous slide, the previous one, just after that.
Was he a smoker?
No, he was not a smoker. So it was a limb shaking TIA according to our diagnosis. And the thing is, even if an MRI epilepsy protocol was done, then that would have not diagnosed anything, because the brain would have been clean, and MRA was required, because so probably when treating such patients with normal EEG, his EEG was erroneously reported as cortical dysrhythmia, which is very vague, but we didn't find anything in the EEG. It only showed some artifacts. No interictal epileptiform discharges were seen. So MRA was required. In this patient, he couldn't do the MRI because of his metal implant, but even if he did it, that wouldn't have diagnosed anything. Next slide. So we took more history from his mother, and she reported that he had multiple episodes of abdominal pain about a couple of hours after meal since the age of 28 years. And there were a few episodes of hematochezia that she reported only after we asked her specifically. So a few episodes of hematochezia was there, and the patient had been seen by a gastroenterologist. After that, after the blood in stool, uh, uh, and UGI endoscopy and colonoscopy were both done, and there was no ulcer. He took PPI, digestive enzymes, and dietary modifications were done. Next slide. So, what was this abdominal phenomenon that he was having?
Could be ischemia.
He was having probably the mesenteric ischemia. That is why he was having abdominal pain about 2 hours after taking the food, and the hematochezia, it's expected to have been containing maroon colored stool rather than fresh blood. Next slide. But naturally, the patient was not able to talk at that time. So this was mesenteric ischemia, diagnosis in hindsight. Next slide. So regarding the management, the stroke was managed conservatively according to protocol. The decompressive hemicraniectomy was planned, but he responded well to the conservative management. Minor complications happened. He needed a tracheostomy to facilitate early weaning from the ventilation. The tracheostomy could later be removed. With medications and physiotherapy, he gradually regained consciousness, the ability to speak with some residual dysarthria, of course, and to recognize people. And after some follow-up, he has become able to walk also, but his left upper limb power still remains very poor. Next slide. In the labs, most of the lab works were unremarkable. The only important finding we had was homocystinemia. And previously, when he was having all those fatigues and other things, probably the multivitamin he was taking probably contained some high dose of methylcobalamin and folate, probably some dose of folate. So this homocystinemia was probably it had decreased for a short amount of time, and he was feeling better. Later he stopped it. And apart from this homocystinemia, we didn't find any other metabolic abnormality in his blood work. So this was very strange that because of only the homocystinemia, he had all these, but plus the sedentary habit was there. Next slide.
Was he vegetarian?
No, he was not a vegetarian. Bengali guy. He took, used, but one important thing is he didn't like fish that much. He used to consume some meat off and on, but good amount of vegetable, but not a strict vegetarian.
No, but he is a Bengali.
He is a Bengali, but he didn't like
non-fish eating Bengali.
Not fish eating Bengali. That's a rare person got a rare disease.
Yeah.
And the further radiological investigations revealed that he had peripheral artery disease, mesenteric artery disease, and minor coronary artery disease. The CAD was not major one. He didn't need any stent for that. So this was what we had in this patient. Next slide. Okay, the next slide, I'm not going to present this one. So let's stick to the previous one. Sure.
Yes, Dr. Gajri.
Yeah, it's a case of homocystinemia, young stroke. And I haven't seen these limb shaking TIAs. Probably most of the patients, they come on a stretcher. So, but anyway, I'll look for them also. Or perhaps I have diagnosed them as focal seizures treated with anti-epileptics, thrombolized, and I may have missed it. That's why I wanted to see a video. I'll keep that in mind. Well,
actually, I also couldn't see that because all those happened before the stroke.
And you would be giving him something like a multivitamin preparation lifelong, along with antiplatelet agents. And by the way, what was his apolipoprotein?
Apolipoprotein A was we did lipoprotein little a, which was a little bit mildly raised, not that much raised.
Well, that is a big risk factor we are seeing, especially in our Indian populations. I mean, besides cholesterol, I don't think is such a big problem as compared to apolipoprotein.
Yes.
And we don't have a drug actually which will treat apolipoprotein, but we definitely give them blood thinners, antiplatelets, and try and bring the LDL to less than 70, which is not always very easy, but we do that. So there would be a drug for apolipoprotein treatment also coming soon. Phase 3 trials are over, but that's another topic.
Yes.
Anyway, nice case.
How much was the LDL, Dr. Kaushik?
Yes, sir.
How much was the LDL?
The LDL, initial LDL on presentation, it was around, I don't remember the exact value, it was around 130.
100 and?
It was just below 130.
Below 100.
Okay,
below 130.
Okay.
We brought it down.
What was the cause of premature atherosclerosis?
premature atherosclerosis in this patient. Actually, we expected worse cholesterol, worse lipid reports, but the patient basically had done all these tests much earlier also, of few years before coming to our hospital, before having the stroke, and at that time all the workup was normal. And what we found is a little raised LDL, and he didn't have, other than the homocystinemia, he didn't have any prominent risk factor for such severe atherosclerosis, generalized atherosclerosis. So this is very atypical that a young person who is a non-smoker has such severe atherosclerosis, generalized. He was sedentary. He started exercising around the age of 28 years. But this is quite strange. That is why I presented this case, because despite not having the most well-known risk factors, he had this with a little bit raised LDL and hyperhomocystinemia only. He had this generalized atherosclerosis.
Many times we don't find a cause. Of course, we don't very extensively do coagulation studies, but in young strokes, we many times don't find a cause.
Yes.
And we are groping in the dark and treating them with statins and antiplatelets. But that is my experience over so many years, that whatever is possible, you investigate, and still you don't come to a cause. So this probably is one of the cases
Yes,
like
sir.
that. But the
We had also
we
done the thrombocyte profile and everything, and other than the homocysteine, everything was normal.
yeah, that's what usually occurs, and we still are left without a cause many times.
Hello, sir.
This is a nice case indeed.
Hello, sir.
And both the
Yes.
cases were
Kaushik, sir.
Yes, sir. Yes.
I want to know कि limb shaking TI is basically comes with external carotid artery stenosis and then gets cerebral recurrent TI, like phenomena.
Actually,
mostly it is internal carotid artery
internal carotid.
narrowing.
Internal mostly.
Yes, sir.
Most commonly internal carotid.
Yeah.
And,
But any large vessel, huh? I mean, large vessel meaning usually it's internal carotid, but this is the first time I've seen it with MCA narrowing. But I suppose it can occur.
Because of that, probably since in his case he had only right MCA narrowing, that is the reason probably that his left upper limb was more involved than his left lower limb. Most of the time his left lower limb was spared, and even when the left lower limb jerks were noted, it would recover very fast, while the left upper limb would take some time to recover after the limb shaking TI.
You know, some years ago, 3-4 years ago, we had an elderly gentleman, about 75, 78. He came with these limb shaking TIs, many of them, and there was severe carotid stenosis, and we did an endarterectomy, and they completely disappeared. I talked to him. He's from Bhopal, and he had come here to Pune. And recently I had a video talk with him about a week back, and all those limb shaking TIs have disappeared after carotid endarterectomy. So really, it was a really eye-opener case, because as soon as he lay down, he was perfectly good. As soon as he stood up, the whole limb on the right side would shake, and he couldn't walk because of that. And immediately after the carotid endarterectomy, he completely improved. So it was a really eye-opener case. Regaukar has asked, were you not concerned about the bleeding through skin before thrombolysis? We discussed this point. Dr. Garajare had raised it also. And as it was superficial and it was a compressible site, we were not concerned. And that was not in our mind a contraindication for IV thrombolysis. And nothing happened. He didn't bleed from there. And, it was just there were superficial blebs, and it was a scald. It was not a deep wound. And it was still compressible. It was on the abdominal wall. And we never really considered it as a contraindication. And nothing happened. So compressible site, say a tooth has been removed, you can compress it. We had a patient who had epididymal cyst, which was operated. And because aspirin was stopped 2-3 days before, that epididymal cyst surgery after that immediately got a stroke. So we thrombolized him and we said, okay, you press on the scrotum if it bleeds, but it didn't bleed. It didn't bleed. And pressure was given on the scrotum by the patient's other hand, which was normal, and nothing happened. This was some years ago. So, or corn is removed or piles are done. Okay, it's a compressible site. You can still go ahead. So don't think that these are contraindications. If it is a deep-seated thing, like a retroperitoneal bleed or genitourinary bleed or a bleeding ulcer or something, hemothorax, then or brain bleeding, then of course you cannot give IVT. It's too dangerous. But if it is a compressible site, superficial, mild bleeding, please go ahead. Don't worry. Dr. Sunil, would you like to put some closing remarks?
Dr. Kaushik, do you have an EEG of that patient where others are diagnosed as focal seizures and you thought that they are limb shaking TIAs? Do you have an EEG?
Yes, two EEGs were done actually outside. One EEG was reported as cortical dysrhythmia, which I mentioned in the slide. One
was
EEG
reported as what?
Cortical dysrhythmia, which is a very vague thing.
Cortical?
Dysrhythmia. And actually, there
Dysrhythmia.
was,
Okay.
and the other EEG was normal and reported as normal. The one EEG was reported as cortical dysrhythmia, but the so-called dysrhythmias were only artifacts and nothing else. No intellectual.
No, because I would expect slowing on the side where the blood supply is less.
Actually,
Delta
sir,
activity, theta activity. I would
no,
expect
sir.
that, or if there are seizures,
they
No, sir,
reported
I don't expect that,
cerebral
because when the
dysrhythmia.
EEG is done, the patient is lying supine, and then the blood supply to that area at that time is not less. So in the EEGs, you're likely to miss.
Anyway, it was a learning point for me. Limb shaking TIAs. Next time, I mean, it's a learning point.
Yes, I think we've had a wonderful discussion with two wonderful cases, and we've, as usual, learned something. Small steps we learn every time, but they are important steps. And as we go ahead and we become better and better in treating stroke, I'm sure the audience also would appreciate that. And I now hand over the mic to Dr. Ronak.
Yeah, we learn neurology stroke by stroke that way.
Or TIA by TIA.
TIA by TIA. See more and more. Just one question. Have you used Tyvalzi? Some people, they come and they talk a lot
I
about
haven't
it.
used.
Because they told me that all the big doctors in big cities are using it and you're not using
we
it.
haven't used.
So I said,
There was once a stroke conference in Chennai, which I attended, and all the posters which were put, which included Strocet, Tyvalzi, and some other, all those
But even-
preparations. And one foreign speaker said, "Ki, what are all these drugs? We have never heard of them. And they
That's
are
true.
advertising only these drugs, and they are not advertising the usual antiplatelets and the thrombolytics. And which are these drugs which they are advertising, because we have never heard of them."
Yeah, aspirin doesn't cost much.
Yeah.
Statins don't cost much.
No.
But all these drugs cost a hell of a lot of money.
So these are advertised the most, and they tell me that they have a turnover of 100 crores and this and that, and they try to induce me by saying that XYZ is using it and XYZ big shot here, there is using. But I say, please get lost. Till I'm satisfied, we cannot use these drugs and we don't recommend them. Yes, Dr. Ravnak, I think we're getting on in time.
No, sir, it was a wonderful discussion, and I'm sure everybody who's heard all of you discussing has gained various clinical pearls through this no thrombosis workshop. So thank you so much, everyone, for joining in today. And thank you so much, our esteemed panel, for this wonderful discussion. So,
how many people attended?
Sir,
currently it is 196 as of now, almost 200.
Oh, that's a lot of people.
No,
Yes,
no,
yes.
it's not good enough. We've had 300, 350, 400 also.
Yes, yes.
So I think everyone is in the Ganpati mood. And I don't know.
A wrong day to hold it.
Yeah. No, it's not wrong. 200 people will benefit. Yeah.
Yeah, they will.
Even if 5 people are there, it's okay. Those who attend benefit. Those who don't attend don't benefit. That's it. So Ravnak, thank you so much, and good night, and
good night.
happy
you,
holidays.
Yeah, thank you, Dr.
Okay.
Ronak, and thank you, Nasli, and all the others, Gajanan and Kaushik. Thank you very much. Good night.
Good night.
And have a nice Ganpati season.
Yeah. A noisy Ganpati season. Chalo, bye.
Okay, bye. Good night.
So much. Ankit, we can stop. Ankit?
Yes, sir. Thank you.
Thank you so much.
Bye, sir.
Please close the meeting. Yeah.
Thanks.